And let's now welcome Engineer Klára Doláková, a new voice in integrative medicine research, whose interdisciplinary background bridges science, ethics, and healthcare policy. A doctoral student in applied ethics at Charles University and a researcher at the Royal London Hospital for Integrated Medicine, she will share insights from her award-winning study on collaboration between healthcare professionals, researchers, and TCIM practitioners. Whenever you're ready, Mrs. Doláková.
Thank you. So good afternoon, ladies and gentlemen. First of all, I'd like to thank very much to the whole organization team. You've done a marvelous job, so thank you very much. And as it's getting quite late in the afternoon, I'd like to wake you up a little bit with a bit of a personal story. And that is a story of my PhD journey, which began in 2019 at the Faculty of Humanities, Charles University in Prague. And back then, I had a curious question. Can traditional complementary integrative medicine approaches be integrated within the Czech healthcare system? And if so, when is it ethical to do so? And because official reimbursement is not happening in Czechia, I had to seek my answers in the environment when such a phenomenon occurs. And so 6 years later, after a research internship at Southampton University, after a very complex qualitative study in the UK with expert participants, after over a year-long analysis using the framework methodology, after a research fellowship at the Royal London Hospital for Integrated Medicine that lasts until today, and one baby daughter later, I can finally present you with my answers. And as the motto of this Congress says, health knows no boundaries, let's seek what unites us. It is time to start cooperating. Well, I'd like to humbly add to it by presenting you with models of cooperation that work in practice within the UK healthcare. And these models were constructed based on in-depth interviews, which are part of my PhD project. So, but before I present you specific models, I'd just like to clarify a little bit of terminology, which will be just a brief description so that you know. So by integration, I mean that formally called TCIM modalities are reimbursed within the National Health Service as any other healthcare services. So we can call these a normal healthcare service. By incorporation, I mean that TCIM modalities are offered in addition to other healthcare services. And finally, let's get to business. So I identified two integration models. And the first one, integration model, is basically when the modality is reimbursed by the NHS in specific diagnosis. So it may be an acupuncture in chronic pain, for instance. Or they also offer mindfulness-based stress reduction in depression, yoga for certain diagnoses, and so on. Let me add that this approach is very biomedical, so you apply certain TCIM approach to certain diagnoses. So the second integration model is when formally called TCIM practitioner gains statutory registration. So they can work in healthcare facilities alongside other professionals, similar to, for instance, a physiotherapist. A typical example from the UK are osteopaths and chiropractors. Sorry. And what is interesting about this integration model is that usually it's led by a very strong professional organization in the country that is able to secure legal registration outside the typical biomedical environment. And now let me show you 4 incorporation models. So the first model is the healthcare professional plus model, okay? So imagine a typical healthcare professional, be it, for instance, a physiotherapist, who's providing one of the TCIM modalities. So they've got additional training in TCIM modality. And the difference from integration here is that they incorporate this modality, but usually it's paid by the patients themselves or by a charity. So the second incorporation model is when a TCIM is the TCIM practitioner plus model. So imagine the same thing, but the other way around. So the TCIM practitioner gets additional training in one of the particular medical field. So, for instance, palliative care. An example from my research would be a herbalist working in a hospital ward. And because this model is quite unique, so I'd just like to add some more information. So usually those TCIM practitioners must meet similar entry requirements to any other healthcare professionals. It is very much depend on the healthcare facility, how they accommodate such a practitioner. And usually this model is created very uniquely through negotiation of passionate individuals in the healthcare system. Now we've got the TCIM practitioner model, so without the plus. And basically, in simple words, it means that a TCIM practitioner is volunteering within a healthcare setting. So an example here would be a spiritual healer working alongside a doctor in a gastroenterology hospital ward. And very interesting thing about this particular example is that it actually led to a research collaboration later on, which was based on this and opened some more doors. And the last incorporation model would be healthcare professional TCIM practitioner model. So it's basically when they work alongside each other. Typically in a GP practice where, for instance, the acupuncturist is renting a space and the patients can be referred there by the healthcare professional. They can also distribute information materials like leaflets and so on for the patients in the waiting halls. And usually these services are financed privately by patients or by charity funding again. And before we proceed, I'd just like to add that all of these cooperation and integration models are specific and have certain ethical implications, but I'm talking about these more specifically in my research PhD project. And now a little game to play and to see whether you got what I tried to explain to you. So here is, in front of you is a quote by one of my participants. Okay, so I'm just gonna read it out loud for you. Perhaps another model is for GPs to work alongside complementary therapists. So in the GP practice, there may be an acupuncturist, one osteopath or herbalist, or a chiropractor or something like that that works alongside the GP. Now, my question to you is which model I'm talking about, okay? Which incorporation model I'm talking about. So we had the healthcare professional plus model, we had the TCIM practitioner plus model, we had the TCIM practitioner model, and we had the model healthcare professional TCIM practitioner working alongside. Which one do you think this is? Do I hear an answer? I don't, but I'm going to tell you anyway. So it's the last one I was talking about, the healthcare professional, and you're nodding, so you thought so. Yeah, I knew you knew. And another one, because it's good to play. So another quote, she had worked at hospital for several years for free, and then we audited those results, and the audit of those results was a preliminary data which allowed us to apply for funding, which we got from the big lottery to do a clinical trial of 200 patients with inflammatory bowel disease and irritable bowel syndrome. Which incorporation model do you think we're talking about here? So the spiritual healer was volunteering in the healthcare facility, which is a bit of a lead. Okay. It was this one, okay? So TCIM practitioner model, volunteering in the healthcare facility. Okay, so what's left to say? At this point, I'd like to emphasize the magic ingredients to cooperation, so the circumstances behind these cooperation models. So basically, interpersonal relationships, and the ability to build those with one another, which leads to the next key ingredient, and that is openness towards other approaches. And the openness leads to knowledge of the possibilities of use of the TCIM interventions. And lastly, and unfortunately for the public healthcare system, no need for extra funding. And now, probably the key thing of the whole presentation. My question is, can we apply this in Czechia? My answer is maybe. Maybe. My study is qualitative, so it represents experiences of a certain phenomena in a specific participant group, which means that the results are not generalizable to the whole population in the UK or in Czechia. However, there is one key message I would like you to remember, and that is that all of the cooperation models that I presented here are mainly led by enthusiastic individuals who can establish and build contacts with one another. So the key message here I'd like you to remember is that an individual can make a system change. 21 of my research participants represented this enthusiastic individual who would work beyond the scope of possibilities to build up something unique with very limited resources. And it seems like the growing platform here in Prague includes more than just one individual. Actually, 2 years ago, almost 2,000 viewers from 55 countries around the world watched this particular congress. So today, I'm here to ask for your help as my research curiosity continues. Can similar cooperation models work in Czechia? More research needs to be done to find out. So if there's anyone from the healthcare sector, academia, research, TCIM practitioners who would like to find out with me, please let's keep in touch, either through the QR code, which leads to my LinkedIn profile, or you can directly just email me, and let's find out together. Thanks a lot for your attention.
Just a minute. We still have about 5 minutes left, so maybe if there are any questions from the audience for Ms. Doláková. I do have one, but is it okay if I ask one? Okay.
You want to ask me a question?
Yes.
Oh, okay.
Just if, yeah?
Right, yeah, no problem.
What key lessons from the UK experience can be useful to other countries? Could be used.
Okay, key experiences that can be used. Well, that it doesn't have to happen top-down, meaning it doesn't have to be, I mean, in an ideal world, the system would be interested in making certain changes and applying the integrative approach as the WHO talks about, for instance, in their strategy. However, there can be a lot done bottom-up, so from the perspective of TCIM practitioners, if they're able to possibly make those connections and yeah, be able to build them up. They can start cooperation models that I was presenting like that, and it can work.
Great, thank you very much. And I saw one more question.
Fantastic.
Thank you. Just a second. Does it?
Is it? Yeah. It's a very small question. You talked about UK models, and you talked about that how an individual can make change in a Czech model. So what's the one element or few elements of UK models that would never work in Czech model or Czech public health system, and why is so?
Okay, so that's a tricky question. So what's something that wouldn't work from UK here? I think the problem in Czechia might be, and again, one of the secret, or not secret, one of the magic ingredients I was talking about is that we need more openness towards other approaches. So my worry in our environment is that the openness is quite limited, and there is no actual academic interest in the topic of TCIM in general. So, but I think, and with events like this one, which I consider very important, the voice of TCIM gets heard. So this can be obviously resolved. What other barriers there might be? We need stronger professional organizations, definitely, and their voices to be heard in order to apply that practice. There might be a cultural difference, because obviously the UK is a very multicultural environment. So I assume it might be a bit harder for us to accept things like Ayurveda or traditional Chinese medicine because of those cultural differences. But I believe that we're sort of crossing that line here. And again, that's why I feel that these events are very important, so that we stay open-minded and we start to grow that curiosity and hopefully more academic interest. I hope that I answered your question.
So thank you very much for your answers and for sharing your research with us.
Thank you very much.